Greetings and welcome to the MHA Alumni Webinar. I'm Megan Lafine, Assistant Director of Alumni Relations at the School of Public Health. Thank you to all alumni, students, and friends of the MHA program who have made time to join us live today. Today's webinar is the first webinar hosted by the MHA Alumni Association and was planned by the Education and Engagement Committee. We are excited to offer this webinar to encourage and provide lifelong learning to both local and distance alumni. We hope to offer more webinars in the future as part of an ongoing series. I'd like to thank the University of Minnesota Alumni Association for hosting this webinar on their platform. We are very grateful for their partnership. Before we get started, I'd like to go over a few items so you know how to participate in today's webinar. You have joined the presentation listening using your computer's speaker system by default. If you would prefer to listen over the telephone, just select telephone and the audio panel of your GoToWebinar panel, and the dial-in information will be displayed. If you experience audio difficulties while listening via your computer speakers, this can be caused by having multiple software applications open, which can use up your computer's bandwidth and affect network performance. Listening in on a wireless signal may affect performance as well. Please feel free to close any unnecessary applications on your computer. Questions are welcome and you may submit them at any time. Please type your questions in the questions panel on your GoToWebinar control panel. We'll be monitoring them along the way and we'll address all questions at the end. Please submit your questions, ideas, and tips. This is going to be a fun conversation and we want to hear from you. And now I'd like to introduce the presenter of this webinar, Mr. Ladd Udy. Ladd is the Director of Population Health and ACO for Mercy Health, an integrated delivery system serving patients in southern Wisconsin and northern Illinois. In his current role, he oversees system-wide population health strategy design and implementation for an ACO comprised of 20,000 beneficiaries in the Medicare Shared Savings Program. Prior to his career in healthcare, he spent 8 years working for a large national bank, mostly in management and consulting roles. He completed his Master of Healthcare Administration degree at the University of Minnesota in 2013 and also has a Master of Arts in a Master of Arts in Organizational Leadership from Gonzaga University. Please welcome Mr. Ladd Udy.
Well, thank you, Megan. It's great to be here. One of the things I know I appreciated as a student at the University of Minnesota during the MHA program was the lunch and learn opportunities to learn how alumni were tackling different real-world problems and looking at different ways to solve those and creative solutions to those problems. So I'm excited to be here and to participate in that. And I'd like to thank the Education and Engagement Committee for providing this opportunity to participate via webinar so that more of us can network and broaden our knowledge base and see what our fellow alums are up to. So as the title indicates, we'll discuss today population health and how that can be used, how fee-for-service can be leveraged to transition into alternative payment models. I'll tell you what we've been working on. We by no means have everything figured out, but we do have a strategy that makes sense for us. I'll walk you through what that strategy is and how we came to some of those conclusions, and we'll look at some of our early results. For starters, we want to look at Mercy Health in general. Some of you may be familiar with Mercy Health System. Mercy Health is actually the product of a merger between what was Mercy Health System, that is, and Rockford Health System, based in Rockford, Illinois. Mercy Health System was headquartered in Janesville, Wisconsin. Our markets touched each other but didn't quite overlap, so the merger created a larger contiguous market. We serve more than 60 communities in both southern Wisconsin and northern Illinois, or as we like to say, we serve both Green Bay Packer and Chicago Bear fans. Although Packer fans are somewhat in mourning today, that does make for some good, that rivalry makes for some good internal banter given our split across the state lines. We do believe in employing physicians. We have nearly 900 employed physician partners, what we call W-2 physician partners. The Majority of physicians who practice at our facilities are employed. We do have some who have who are credentialed, who have privileges, but the majority are employed by Mercy Health. We do have 5 hospitals, and with another one under construction. We do have a wholly owned insurance company, a provider-owned HMO, which we formed in the 90s. And rather than abandon that concept, we actually held on to it. And given the state of the market today, we're glad that we did that, because it has taught us quite a bit about the ACO world, for example. And we have over 80 different outpatient sites in quite a few different communities. So that's a little bit about Mercy Health. Now, to set the stage for our strategy, we need to look at what's happening in the market and the industry. Given this audience, this probably isn't going to be new to you, but how we've put the pieces together within our context might be a little bit different than what your organization sees, for example. So we'll walk you through those pieces. You've probably all seen graphs similar to this. We're all aware of the issue of healthcare spending in the United States. This is actually a few years old, this chart from the OECD. But healthcare spending remains close to 18% of GDP. It reached $3 trillion in 2014. And health insurers are very aware of this, because most of the dollars flow through them first before going back out to providers, etc. Medicare is one of those insurers. Here is a look at the projections, or the projected spending. These were done several years ago, actually, by the Congressional Budget Office. You can see what the actual spend was of the first few years here on the left-hand side. The last couple of years, the actual spending has exceeded what the projections were. Now, if you look out just a few years' time, we're looking at 2022, potentially $1 trillion spending in Medicare alone, let alone all the commercial and Medicaid spending. So this is significant. There's some urgency to the issue, and we want to be part of the solution. I think most of you on the line are probably in a similar situation. You want to be part of that solution in curbing the spending, but it is a significant challenge, and it has to be done very carefully. Now, where CMS is spending the majority of their money is on chronic disease. Again, probably not a surprise, but this infographic shows some of the statistics that CMS sees in their claims and what they're paying out. So 3/4 of the spending overall in the U.S., it ties back to chronic conditions. Now, it shows up in the form of ED spending and inpatient spending and everywhere across the board, but that's the root cause that it ties back to. Now, there's increasing enrollment in the Medicare program. More than 2/3 of them have beneficiaries have 2 or more chronic conditions. And Medicare is unique in the sense that they tend to keep their beneficiaries for life, whereas a commercial payer might have a member on their books, using their terminology, for a few years. Medicare tends to have them until they pass away, so they look at it a little bit differently, perhaps, particularly because a lot of the spending happens during the last 6 months of life. So it's a pretty significant challenge for Medicare, and they want to engage providers in managing chronic conditions. A couple of years ago, they set some goals and basically said this fee-for-service model isn't sustainable. We want to start paying providers and hospitals, for that matter, differently than we do today. Some of you may have seen this infographic before. In early 2015, CMS came out with the goal that they were going to tie 30% of their spending to alternative payment models by the end of 2016, and 50% of their spending to alternative payment models by the end of 2018. Now, they met that goal almost a year early. In early 2016, they stated that they have reached that 30% spending mark. Now, that's interesting, because these were regarded as very aggressive goals when they were first issued. Some people in the industry somewhat scoffed at it a little bit and felt like it was too aggressive, but they have gotten engagement. Now, track 1 of the Medicare Shared Savings Program does count here, so that's perhaps a little bit generous, but nevertheless, they have gotten the engagement that they were looking for. Now, how they define those payment models is listed here, and we won't spend a lot of time here, but basically on the left you have the fee-for-service, just straight, you perform X service, you receive Y dollars, and that's the end of the transaction. Category 2 is more the performance, pay-for-performance type of program, such as value-based purchasing on the hospital side, the physician value-based modifier. Category 3 and 4 are what CMS considers alternative payment models. So they want to be doing 50% of their spending in categories 3 and 4 by the end of 2018. Category 4, there aren't too many providers in that situation yet, where they're getting basically population-based payments or capitated payments. But Category 3 is where the bulk of the activity is happening. These are alternative payment models such as ACOs, which is kind of the flagship model for alternative payment models. And they're built around the fee-for-service architecture. And that'll be a key to what we're discussing today here in a few minutes. Now, reimbursement patterns don't usually happen at the flip of a switch. It's more of a migration pattern towards different models. For example, this represents it as a very linear process. It's not generally that linear of a concept, but it does represent the shift towards taking on more risk. Now, in our case, at Mercy Health, we do have a provider-owned HMO, so we have 50,000 lives or so for whom we have insurance actuarial risk. We have another 20,000 in one-sided risk here in the middle, but not really any two-sided risk. We don't really participate in any bundle payments at the moment. We weren't selected for any of those mandatory models, but we do have quite a few in pay-for-performance. So at any given point in time, we're all the way across this spectrum. But in general, it represents the migration towards accepting two-sided risk or even full actuarial risk. Now, coming back to Medicare and what they're doing, since they tend to be a driver of a lot of the activity that's happening here, we see this statement from Andy Slavitt, who is the outgoing CMS administrator, and it's fairly telling what this says here, as we see 10,000 people joining Medicare each day, and they're not expiring at that same rate. So there's a net gain to the Medicare program going forward. So this bolded text is the key here. This is where they want to spend their money. They want to invest in primary care, chronic disease management, and prevention. So they've very overtly stated where they want to go with it. That's key and it has played into what our strategy is. So these are some of the ways that they're doing that. For example, they've created codes in recent years since the Affordable Care Act was passed, or even more recently, to reimburse for certain activities that a lot of times were taken care of by insurance companies, by those who bore the financial risk, in order to incentivize providers to build these capabilities so that when eventually the risk shifts off to providers at whatever point in time that happens and is happening, then those competencies and those capabilities are built. So we'll talk about all these things and how they played into our strategies, or our strategy, that is. CMS continues to add codes to the physician fee schedule. And these are on the fee-for-service basis. So things that can be reimbursed on the fee-for-service side that help prepare a provider group or a health system or an ACO for migrating more towards a different type of payment model. Some examples of other preventive services: smoking cessation counseling. Many providers are already providing that on a regular basis. It's been tricky to actually bill for it in the past, but CMS has issued some clarification that makes it quite a bit easier to bill. So that's another one that we're looking closely at. So activity that's already happening, but things that you can bill for. Now, another thing that's important with these types of models and alternative payment models is risk adjustment. With Medicare, they use what's called the HCC Risk Adjustment model. HCC stands for Hierarchical Condition Categories. Basically what this means is CMS will look at the sum total of encounter diagnoses in the claims for the population assigned to the ACO, to Mercy Health in our case. If our population looks healthier than average, then our spending benchmark is set lower, because in theory we look healthier on paper, and CMS should be spending less money on our population. Now, that's a problem if our documentation isn't accurate, if it doesn't reflect the actual situation of our patient base, of our population. So that makes it more difficult to succeed in the model. Now, obviously, you don't want to overinflate that, obviously, because that gets you in trouble on the other side. But you do want to make sure that it's accurate and that it tells the story of your population. Now, spending benchmarks are risk adjusted, but capitated payments are very sensitive to the risk adjustment. Medicare Advantage plans understand this very well, and they do a lot to engage providers in getting their patients in to assess the different conditions to ensure that they show up, because it resets every year on January 1. So somebody has diabetes, they come in and see us, and it's still January, and we document their specific type of diabetes as a condition, and it goes out on as an encounter diagnosis on that claim. Then that patient's risk adjustment, individual risk adjustment factor, will be that the diabetes will be accounted for that patient. But if, let's say in 2018, that patient either doesn't come in or they come in, but we don't document that specific condition for whatever reason, on paper it looks like that patient doesn't have that type of diabetes anymore. It went away, and it will mess up our risk adjustment. So this is something that it lends itself to clinical documentation improvement on the outpatient or ambulatory side, which is a relatively young field. Most providers haven't had a strong reason to pay attention to that until just recently. So that's something that will factor into our strategy as well. Looking at the what else CMS is doing. We have this other piece of legislation. We know the Affordable Care Act is out there. It's been there for some time. The MACRA is another piece of legislation passed in 2015, which was very bipartisan. Over 90% of the House and Senate voted yay on MACRA. So it's been referred to as a bipartisan love fest. It's very widely accepted, and it's likely to stay in place going forward. But what CMS has put in place to deal with MACRA is the Quality Payment Program, or how they're going to administer the program. It's called the Quality Payment Program. And what that does is MACRA changes how providers are paid. So providers have to choose between being part of an advanced alternative payment model or being part of MIPS, the Merit-Based Incentive Payment System. MIPS is also a new program for 2017. It's basically a consolidation of existing quality programs. So the Value-Based Payment Modifier, the PQRS program, and the Meaningful Use program have now been consolidated into MIPS. And there are adjustments which we'll look at here based on how you do. It's a pay-for-performance program. Now, if you're part of an advanced alternative payment model, it does require you to take on some downside financial risk. However, CMS is offering a 5% lump sum bonus on your Part B Medicare payments if you sign up for one of these models, and you get out of MIPS. You don't have to deal with those potential adjustments. You still have to report quality measures in your alternative payment model, but you don't have to deal with this MIPS-specific models. So that's a nice carrot, the 5% that's put out there, and certainly would want to factor into an organization's strategy. Now, how MIPS looks, it's also pretty significant. There is some downside risk here if you don't do well. So either an individual provider or a group will be assessed a score anywhere from between 0 and 100, and then that score will be compared against a threshold. And if your score is above that threshold, you'll get an increase in your Part B payments. If your score is below that, you will likely get a decrease in your Medicare Part B payments. Now, a lot of providers have quite a few Medicare patients. A lot of their dollars are tied to Medicare, so that's pretty significant. In the case of a health system, that's our biggest single individual payer here at Mercy Health. So that's noteworthy for us and something we need to ensure that we have a handle on. So that's the situation at large. We have developed strategy in response to these market factors, but as they say, if you've seen one strategy, then you've seen one strategy. So this is the direction that seems to make sense for Mercy Health given our context, and we'll walk you through some of that, what some of that specific context is for our organization as well. These are some considerations that we have considered that I imagine other organizations consider as they try to map out their future with these types of models. For example, we need to look at what is CMS doing, because they tend to be a driver of these types of alternative payment models, and what are commercial payers doing. That could vary widely in your market. Commercial payers may be ahead of CMS, or they may be following suit. In our case, they tend to be following suit more so than leading the way. We also had to consider how have we done on both quality and cost. Those are two things that are the crux of all the alternative payment models, so you need to assess where you're at. We had to do that. Of course, we want to look at competitor activity, what's happening in our markets. That may impact our choice, as with most strategic considerations. And the organizational culture, how ready are we to take on this type of a change, because it is a change. We also need to look at what type of infrastructure and competencies do we already have. To borrow a phrase from our neighbors up north at ThedaCare, the terms mindset, skill set, and tool set. Do we have the right mindset? Have we communicated what we're really trying to accomplish? Do we have it down into our hearts of our providers and our staff and our administrators and everyone? Do we know what we're really trying to do here, and do we understand the reasons behind the initiatives? Do we have the skills to do it both clinically and organizationally and project management-wise? And tool set, things like claims data, analytics, different dashboards. Do we have the tools that we need to manage these types of arrangements? We started by looking at our quality performance. This is as an ACO. Our most recent data is from 2015. These ACOs listed here are ACOs that are based in either Wisconsin or Illinois, since those are our most our markets and our neighbors. So in 2015, we actually had 2 ACOs because of the merger. Each legacy health system had their own ACO, and in fact, those just were merged into one as of January 1 of this year. So it'll be the same for 2016. But these are sorted by quality score from high to low. You can see the ACOs on the right-hand side that have P4R listed. That stands for pay for reporting. It means they were in their first year in the program, and if you report your data successfully, basically you get a P4R score. You get a pass. You don't get an actual score. So those starting with Alexian Brothers and moving down, these are the ACOs beyond their first year that did get an actual score. You can see one of ours, it was the first year in 2015, so we got a P4R. Our other ACO came in at 97.97, which we were very happy with. Came in ahead of many of our competitors, most of whom are larger organizations and have more resources. So I felt very good about the quality side, and we were sure to emphasize that with our providers for historical performance. Now on the cost side, you also want to look at expenditures per beneficiary. So this is sorted, again, the same list of ACOs sorted from high to low on the right-hand side. So the organizations at the top, Medicare spent more per beneficiary with those ACOs than they did those towards the bottom. You can see one of our ACOs is towards the middle, the other one more towards the bottom. So historically, we've been a high-quality and relatively low-cost ACO when you put the two together and take a weighted average. That's important considerations for us. Now, that's just compared to our neighbors. When we look at on the national scale, on the quality side, one of our ACOs was in the 87th percentile among ACOs who got an actual score, so we felt very good about that. Our other ACO didn't get a score, so we weren't able to accurately compare there. But on the cost side, where lower is better, one of our ACOs came in fairly low, and in the bottom quartile there, and then another ACO about right in the middle. So again, averages out to the 35th or 40th percentile. So we're a high quality and relatively low cost to start with, which is important as we look at the different models that are out there. So what that led us to is to a strategy where we say the patient is the center of everything we do. Primary care is the center of the care model to care for the patient. That's where patients, the majority of them, we want them to be managed in that setting. Now, some patients, it makes sense to manage them in oncology or cardiology. But the majority of patients, we want the primary care provider to be the quarterback. And that's not unique to us. Those of you who are familiar with population health know that it centers heavily on primary care. We also know that we can learn a lot from the Medicare Shared Savings Program experience. We've been in 3 years now. We've learned a lot so far. We aren't sure. We hope we can achieve shared savings. Based on the aggregate data, though, we are less likely to, given our historical context. And we're also in a low-cost area, too, since there is a regional factor there. So if you look at the aggregate data and those ACOs who were able to achieve shared savings, the average benchmark is quite a bit higher than what our benchmark is. And so it's kind of like asking somebody who runs a 6-minute mile to trim it to 5. It can be done, but that incremental improvement is more difficult than, say, somebody who runs a 13-minute mile and you're asking them to trim it to 12. There's a lot more room to come down there in the first place. So now that doesn't mean that we aren't trying to. We are trying to reduce expense. We are trying to manage these patients in the most cost-effective manner possible. But the getting the savings isn't the crux of the strategy per se. It's more about how do we prepare for risk-based models? How do we learn from this and develop the competencies so that we're ready when the right model does come along that suits our situation? We also know that we can collect fee-for-service revenue for things that we would want to be doing anyway, even if we were at risk. Some of those things I mentioned already, and we'll go into a little more detail there. We know that we do have some downside with MIPS, for example. We need to continue to focus on those quality programs. However, the upside of that is that MIPS has 4 categories. One of those categories is called quality. Those quality measures directly overlap with the ACO quality measures that we have to submit in the shared savings program. So we have a double reason to do well in that particular program. And then there are some other programs, Med Advantage plans, where we have fairly large populations that we would want to try to improve quality and capture some of the pay-for-performance dollars. We also know that if we're moving towards a risk-based model, that we need to improve our accuracy of our HCCs, that we need to capture those on an annual basis. Our providers need to know what it is. We need to build tools to make it easier for them to capture them, and that's an ongoing effort. As I said, that's a relatively young field because most providers haven't had a really good reason to pay attention to risk adjustment. It hasn't been factored in unless they were getting capitated payments from, say, a Med Advantage plan. Those providers are probably, hopefully, pretty tuned into that. But many providers are more like in our situation where they haven't had a strong incentive to really manage that. And we know that we need to continue to build functionality within the EMR. Providers are in there working every day. How can we make it easier and not have to switch back and forth between registries or between different tools? So tools such as the Healthy Planet tools, which are created for population health, and the ACO dashboard are some of those things that we've been working to improve. So if you're not familiar with the Medicare Shared Savings Program, here's a quick overview of Track 1. This is a track where we can share in the savings if we achieve them. However, we have to hit a minimum savings rate. For us, that's somewhere around 2.5%. So if we achieve savings that equal 2.1%, we obviously reduce spending for CMS, but we don't get to share in any of those savings. So that's one of those factors in the model that we have to factor in as well, especially given our historical performance. But the spending target, you don't really get to negotiate that with CMS. It's set based on historical spending, a regional factor, and a risk adjustment factor. And that's you can forecast that all you want, but what really matters is the benchmark that they give you. Now, luckily in this track, you don't have to repay CMS if you don't achieve savings. So there's no downside risk to it, which is important. It can be used as a learning lab. Don't want to take the pressure off from putting these things in place. But we'll talk a little bit later about why it's generally wise to avoid jumping into risk-based arrangements, particularly with a payer as large and as significant as Medicare. So you want to move that way, but you want to just be careful about the pace that you do it. We will be measured on 31 quality measures next year. That's down from 34 last year. And this is where the majority of ACOs are, at least as of last year. Last week, CMS released their participation for the different programs. I know there were a lot more ACOs that moved towards a risk-based arrangement. The bonus payments under macro may have had something to do with that. Also, a lot of agreements were expiring, and they just felt like it was time to move towards a risk-based arrangement, I imagine. So that may look a little bit different in 2017. However, still, the lion's share of ACOs are in Track 1. So some key initiatives for us. How do we transition from a fee-for-service-based model to a value-based model? A couple of things that we've been focusing on here will show you, tell you a little bit more about what they are and what some of the early results are. The annual wellness visit essentially is a conversation around preventive care. It's a wellness conversation, but it's structured. It needs to be structured. It needs to hit certain things. And we'll talk about some of the benefits of it. Transitional care management is intended to reduce readmissions during that vulnerable time when the patient leaves the hospital and they're in their home setting. And chronic care management is designed to basically pay care management fees for patients that you can show you are coordinating care for. So one reason the annual wellness, well, several reasons the annual wellness visit is important. First of all, it's, as I said, it's designed to be a conversation about preventive care. What screenings are you due for? We have tools built in the EMR to queue up a provider when a patient is due for certain things so that they can make those recommendations. On the quality side, a lot of the measures are tied to preventive care and screenings, immunizations, things of that nature. And so that annual wellness visit satisfies, at least measures have changed a little bit, but as of last year, up to 11 of those measures could be satisfied at an annual wellness visit. That's a lot of bang for your buck on the quality side, and those measures are now the MIPS measures as well. So it's a great opportunity to sit down and have a whole person conversation at least once a year and talk about what their care plan is for the year. Now, prior to doing this, we felt like that was happening at least in spurts, but probably not as comprehensive of a manner as it is now. It's also a great chance to document all the different conditions that a patient has so that the HCC risk adjustment is accurate, all the things that affect their care plan, all the things that factor into the medical decision making. And that eventually trickles through to what ACO's benchmark is and other contracts as well. We have some pretty significant Medicaid contracts, managed care contracts, where that risk adjustment is impacting us. Outside of Medicare, and commercial payers do that as well. And On the reimbursement side, it is favorable. Usually this is done in the primary care setting, and if you take your number of Medicare patients and multiply it by either 108 or 176, you'll get the range of revenue that a provider could potentially bring to their practice for ensuring that these conversations are done. This shows you how we have performed over the last few years. Really, we started to hit this hard during fiscal year 15 or towards the end of 14. We still report separately because we're on different EMRs and billing systems, so these are listed separately. The green bar indicates as a combined health system, which was effective January 1, 2015. So you can see there's quite a bit of an increase there. We're reaching a lot more patients with that annual wellness visit. It is a visit that does not have cost sharing or deductible for the patient either, so there's no charge to the patient for having it. They get one per year. So based on how we've done the first 6 months of 2017, we project that we'll reach about 18,000 Medicare patients with their annual wellness visit this fiscal year. Now that's great progress, obviously, over the last several years, but that's still only about half of the Medicare patients that are seeing us in a primary care setting. So we still have opportunity to improve there, and not to mention those who are seeing us for specialty care but not in the primary care setting. We'd like to manage the whole patient. So we have room still for improvement there, and we'll keep working towards that. But you can see that's a nice boost in revenue, bringing that to the primary care provider practice. A provider who has 300 or 400 Medicare patients could add $40,000 to $50,000 to their practice in wellness visits for ensuring that they're having these conversations. So Medicare's really putting their money where their mouth is. They want these conversations to happen. In fact, I saw a press release last week about how many patients had taken advantage of an annual wellness visit. It's still less than 20% of those enrolled in Medicare. Now, transitional care management, as I mentioned before, this is something we've been working on for the last year or so. This is intended to reduce readmission rates. Now, we found that in looking at the requirements, this is a basic level. I don't want to oversimplify this because it does take a lot of effort to look at, okay, what do we need to document, what do we need to ensure is happening, and then can we actually submit the bill, and how do we actually do that? It took an interdisciplinary group a couple of months to put it together and plan the rollout, and then to go through and train providers on it. But it largely builds on what providers are already doing. We showed the requirements to our providers, and they said, well, usually we have a hospital follow-up visit, but I don't have a care coordinator, I don't have a nurse in my office, and we're generally too busy to call, and so we're not doing the call or the email within a couple of days. But they are doing non-face-to-face services, such as reviewing the discharge report and labs and things of that nature. So on the provider end, it hasn't resulted in a lot of change in what they're actually doing. But now that we have care coordinators working on that, generally when the patient is in front of them, they have better information. They know more about what happened because the care coordinator has been interfacing with the patient and then also with the provider and updating them on the situation. Now this is another one that will reimburse higher. So for example, our providers normally for a hospital follow-up visit are using an E&M code. And these codes only apply to the moderate to high complexity patients based on medical decision making. So in our area, you can see the Medicare rates on the right-hand side. You can see the TCM codes, the corresponding codes, for the same level of complexity on the left. It's about 50% higher. Now, we found that for TCM, most commercial payers are also reimbursing us for this. So this isn't just a Medicare thing like the annual wellness visit is. And in some cases, it's up to $400 for basically what's an office visit paired with care coordination. So it's fairly significant when you look at the number of discharges that qualify, and then you add up the totals, particularly on the commercial side. It can add up fairly quickly. And chronic care management is one that we're just going live with now. We're in the final phases of the pilot, and there was a strategic delay. We knew that some changes were being made to these codes for 2017. Again, this is something that CMS wants providers to be doing. In fact, there's a webinar they've scheduled next month talking about leveraging the value and promoting the value of chronic care management. The adoption has been relatively low because of certain barriers that were in place. Some of those have been removed for 2017. There are still a couple of barriers. It's not perfect, but they are taking steps and listening to the feedback that the industry is giving. So this is essentially if a nurse is coordinating care, a nurse, a social worker, any clinical staff on a provider's behalf, and the provider is overseeing that clinical staff person, they can be reimbursed for a lot of that work, which prior to 2015 there wasn't reimbursement available. So if you were doing that, you were doing it either because you were in a risk arrangement or because you felt it was good for the patient, but you were footing the cost of the nurse, which, as we know, isn't cheap labor. They need to be paid, and paid well for their skill set. So in this case, it will reimburse about $40 monthly, depending on your region. Coinsurance does apply, which is one of the barriers there. CMS states that about 81% of their beneficiaries do have a secondary type of insurance, such as Medigap policy, which may pick up that coinsurance of $8 a month or so. That's what they're designed to do, but we can't guarantee that. So it may or may not be a barrier. We'll find out. Others have said that it's a potential barrier. Now, there is verbal consent required. You no longer need written consent, which was in place until just the end of last year. And as long as the care coordinator spends at least 20 minutes coordinating care, meaning talking to the patient, educating the patient, coordinating with social service agencies, coordinating with providers, there's a whole cadre of things they can do that count towards that 20 minutes. It's pretty easy to reach that if these are patients who have 2 or more chronic conditions that need extra help. But only one provider can bill for it per month, so there are obviously some restrictions in there to prevent double billing. Now, these are some of the required components here. These don't necessarily have to be completed by the provider. The care coordinator can do quite a few of them, but the provider puts the care plan in place. And then the care coordinator helps the patient to comply with that care plan by reducing barriers, arranging transportation, whatever barriers they may have. And the 24/7 access, that can be arranged different ways. In our case, we're all part of the same group, and somebody is always on call and available for urgent care needs. Now, looking at the potential revenue here, this is fairly significant. If you look at our average of primary care, average Medicare patients for a PCP is about 400. Some have 900, some have 200, but on average about 400. And we have about 120 primary care providers across our health system. Now, if we take Medicare statistic that 2/3 have 2 or more chronic conditions, which our own claims data does and clinical data does appear to support, then that would equal 264 eligible patients. So if we were to bill that $40 and coordinate care and show that every month, that's a potential $126,000 in practice revenue for that one provider. Now, the flip side of this, though, is that you have to pay for the nurse or whoever's doing the work, so you'd have to factor that into the potential revenue. But for a primary care provider, that's pretty significant. I will note, though, that 264 patients is a pretty big patient load. That would potentially occupy a care coordinator full-time, because these patients often don't take just 20 minutes. I mean, ideally, if you could cut it at 20 minutes and move to the next one, great, but their needs, as far as what they actually need, often take longer than that. So, and some patients will decide not to enroll, may not see the value in it. Maybe we don't quote-unquote sell it well enough when we present it, or when the provider presents it to the patient. So looking at a more realistic scenario at the bottom, maybe 50 patients enroll at the same rate, could still add a fairly notable sum. For a primary care provider, that's pretty notable to add to their revenue, and is good patient care. That's the more important part, that their patients, their high-need patients, are getting some extra attention, and they don't have to be on the phones or necessarily answering the messages, except for when the nurse feels the need to bring them in. Now, there's also downstream revenue that may occur as a result of that, as different needs are identified, and there's soft outcomes too, such as improved outcomes and quality measures. Obviously, that's what we're really trying to get at here. It's just that the financial part of it is an important component to keeping it sustainable. Now, CMS has made changes for 2017. You can see some of these additional codes that have been added here. We're still investigating these. We don't have a lot of the details, but based on feedback from providers around saying, you know what, some of these providers take longer than 20 minutes, some take longer than an hour. If they do reach longer than an hour, there's an additional code that can be, or a separate code that can be billed. And if they take longer than 90 minutes, then they can add additional 30-minute increments onto that. So they're willing to pay for these complex patients, assuming we, as an industry, spend the time to do that. We're still looking into these and what they entail. We're moving forward with the pilot based on the original code, and then we plan to integrate these as we learn more about them. Now, in 2016, Medicare began reimbursing providers for advanced care planning. Oh, and I should go back and say, this is just a CMS thing at the moment, so Medicare and Med Advantage plans are reimbursing for CCM. Most commercial providers aren't, although there are arrangements where commercial payers, that is, they will pay care management fees if you show that you are an accredited PCMH, for example, or if you show that you are doing care coordination, they may pay you care management fees, and it may or may not be tied to direct activity. So there is that to keep in mind. Now, advanced care planning, as I mentioned before, Medicare is a little bit unique because once people join the roles, they tend to stay there for life. And so advanced care planning is an important service. However, in the past, it hasn't been reimbursed until now. So Medicare came out with a couple of codes last year. You can see them listed here for the first 30 minutes and additional 30-minute increments of just the counseling, whether or not the forms are filled out. Now, obviously, the goal is that you want them to fill out the forms so that you know when the time comes what the patient wanted, and so the family knows and the provider knows, so everybody's on the same page. That's the long-range goal of what we would try to accomplish with that. We've run into some hiccups trying to build this with a couple of the requirements. It doesn't quite match. We had a model in place already that was based on the activity at Gunderson Lutheran, which is in La Crosse, Wisconsin. Some of you may be familiar with their work. They are a nationwide leader in advanced care planning and have been able to reach over 90% of their patients that have advanced directives on file. So very successful model. We've adopted that. It unfortunately doesn't match the direct supervision component very well, so we're still working through that and still looking at it. But a lot of potential there, again, particularly if we're looking at going to risk eventually. Now, we feel like those are some of the major initiatives we're working on as part of this glide path, so to speak, from fee-for-service over towards value-based payment models. But we feel like there are benefits to all the notable stakeholders. For example, patients. Usually, a lot of this preventive care is without cost sharing. Not all of it, but a lot of it is. But we want to ensure that it's timely and that it is done. This is a way that helps us to get there. Now, on the provider side, it helps them manage their patients. It helps extend themselves a little bit through the care coordinators, and they can increase the reimbursement for their practice, particularly in primary care, which is noteworthy. And to be honest, primary care has had a lot of expectations heaped on primary care, and in a way, it's almost like they're finally getting their due, at least a little bit. There's a ways to go there, but maybe being paid more for what they know as opposed to what they do, which is very much how fee-for-service is set up. Now, as a system, this approach helps us stay in step with payment reform. Helps us look at the landscape, if you will, and see where things are going. And we don't want to be caught flat-footed eventually if models are made mandatory. And CMS has taken steps towards that with bundles, for example. We want to learn these things now so that it's not a surprise, so that we're familiar with them and we can manage these things as the migration pattern happens. So we're not usually leading edge, because leading edge is sometimes the bleeding edge too, but we're what we call fast followers, where we're moving with the herd and maybe towards the first third of the herd, as long as we feel like the herd is moving in the right direction. So all stakeholders, in the short term, this benefits, and in the long run, it benefits us as well as a business as we try to shift that mindset towards risk. So in summary, our goal is to move towards value-based models. We're still largely in a fee-for-service world, though. We still are a health system that is anchored with hospitals and hospital-based fee-for-service revenue. So we have to be very deliberate about how we do that. Don't want to move too quickly or too slowly. So we want to pace our care model redesign with how the changes are happening in our markets. We are part of Track 1. We're using that as a learning lab. There's really no downside to it, not only financially, but just from a learning perspective. There's a lot that can be gained from putting these competencies. It gives us a catalyst to put some of these, the infrastructure and competencies in place. Now, it's not the ideal payment model for us. Really, the shared savings program isn't. But we can, if we're part of it, we can pay close attention to how things work, learn how they work from the inside, and wait for the right model to develop. And there are a couple out there that are promising. Or, under MACRA created what's called the PTAC, which is a committee that looks at different payment models that can be proposed by anyone in the industry, and then evaluates them and makes recommendations to CMS as far as which models to deploy in a pilot or to scale them up, models that make sense for different groups and different health systems. We also know that there are ACOs who jumped right into risk-sharing arrangements. We have some neighbors around us who have done that, and it's hard to really understand the benchmarking and the risk adjustment and even the quality reporting. It's not as easy as emailing a spreadsheet into Medicare. It's a pretty significant effort. And the claims data analysis, the claims data from CMS isn't easy to work with. It can be done, but it takes a skill set to do it. You have to kind of be in it to learn it and be doing those things. rather than watching from the outside and hoping that it changes or that it gets better. It takes some practice, if you will, and learning it from the inside. And again, coming back to the concept of, do we have the mindset and the skill set and the tool set? That doesn't happen at the flip of a switch either, but is part of the migration, part of the strategy. Now going forward, we are in a period of potential and likely changes. We don't know. We're likely to see a reconciliation bill from Congress. We don't know exactly what's in it yet. We have to assume that it's being done quickly. So we have to assume that it's being pieced together from other proposed legislation in the past, which has not passed. For example, the HR bill, I think it was 3762, passed the House and the Senate last year and was vetoed by President Obama. That may be a blueprint for what is in the reconciliation bill. I haven't seen it yet. Look forward to looking at it, obviously. Now, another thing, though, that's important for our strategy and for the industry in general is, what is the future of the Center for Medicare and Medicaid Innovation, the CMMI? This is the organization that runs these models, such as ACOs and the bundle payments, and administers all those. And they've really done a lot of, in my opinion, a lot of really good work in moving these things forward, in getting engagement and adoption in the industry. But they've become a target for the new administration, particularly our incoming HHS secretary, because some of those models were made mandatory, such as the comprehensive joint replacement, cardiac bundles that were recently released. The mandatory nature of that really got the attention of certain lawmakers, and they don't like that. So they could potentially defund it through the reconciliation bill. It'll be interesting to see what the future of that is, but it interacts a lot with MACRA here, the ACA does, because MACRA, as I said, was very bipartisan. It's likely to stay in place, and it affects how providers are paid. But under MACRA, you have to choose between either being part of an advanced alternative payment model or being subject to MIPS. Well, those advanced alternative payment models are run by CMMI, so if CMMI is defunded, then providers will be forced into MIPS. They'll forfeit that 5% bonus. They'll have to be part of MIPS and be subject to it. And it's really embedded into the strategies of the industry. Value-based care really is embedded, and a lot of those players who have moved towards those advanced alternative payment models have a lot of clout. So I'm interested to see what comes of that. In addition to that, the Shared Savings Program is a separate statute in the Affordable Care Act. So if CMMI goes away or really doesn't have resources to run it, then who has to run it? Because that would take 60 votes to repeal. It can't be done through a reconciliation bill. So the couple of things are up in the air. If we learned anything in the last year, it's that anything can happen. So we're paying close attention to that, any potential legislation that comes out of there. And strategy, as always, is an organic thing. It's a living thing, and needs to be modified as the market changes. So we're paying close attention to that. But that's our basic blueprint for keep putting us on the path to move from a fee-for-service anchored model into more of a value-based and eventually risk-based model. So with that, we'll turn it over for questions. I think we have a few minutes there to try to address those.
Okay, thank you, Lad. Just a reminder to please type in any questions that you may have, and I will direct those to Lad. Okay, we don't have any questions yet. Give it another maybe 30 seconds, and if there are no other questions, we'll let everyone get on with their days. So, last call for questions.
And I will put my contact information here. If by chance something struck a nerve and you want to follow up, you're welcome to do that.
Let's see, we have a question, is the PowerPoint able to be shared? And thank you. So the plan as of now is to put the recording of the webinar on YouTube, and it will be available on the MHA alumni site. Oh, and so that's that question. We have one question that came in. Describe how your CMS experience has translated to value-based contracting with commercial insurers. Describe how your CMS it's okay. It was repeated twice. So describe how your CMS experience has translated to value-based contracting with commercial insurers.
Oh, sure. Yeah, I like that question. Couple of ways. One, on the one hand, we do have 50,000 lives under management, so it's not like this is brand new to us, but it is different. We're engaging our providers differently with some of this functionality. But so I don't want to overlook the fact that we do have our HMO, which obviously I work closely with to piggyback on some of those capacities. But we are starting to see different, as we renegotiate contracts as a unified health system, we're starting to see different types of programs pitched at us, not just pay for performance. We've been seeing those for a long time. But we've been approached by a major commercial insurer about a similar type of shared savings arrangement, risk-adjusted benchmark, but they'll also pay care management fees, not tied like CCM is. They're lower fees than what CCM pays, but they'll pay us for every beneficiary, every member. And then we can deploy our resources as we see fit to focus on the beneficiaries that we feel, or the members that we feel like are most likely to need some of that help. So we're starting to, ideally we look at getting to a tipping point where we align some of our major contracts with larger commercial payers, CMS, and if we can bring it to one care model so we don't quite have our feet in two different canoes for very long, so to speak, we get to that tipping point and then press it forward that way. That's kind of the long-range outlook. So we're being approached by it. We're not full-fledged on very many other than that major carve-out, obviously, of the 50,000 lives that we are managing at the HMO.
Okay, we have another question. How have you managed the change process with your employed providers to buy into the new reimbursement models?
Ooh, that's a good one. That's $1 million question, or $1 billion question, actually. I wouldn't say that, well, okay. I won't say that we've nailed it. I will say that we have certain advantages to our integrated nature. All of our providers are on one EMR, all our employed providers. We have regular meetings with them where we discuss at the high level, here's what we're trying to do, here are the initiatives that get us there. We've had varying degrees of success. I would shape that as a bell curve. That, on the one tail end we have a handful of providers who are very engaged. On the other tail end we have some who fight us on it. And then the majority are somewhere in between where they kind of get it, but they're busy or they're not primary care, and so they don't pay as much of attention. That's an ongoing thing, the change management process. We try to incorporate the principles that we've learned, but we know that repetition is a key part of that we have to be very forward about here's what we're trying to do, here's why, here's how it applies to you and how you can engage. And that takes, for a lot of times it takes repetition of presenting that again and again and again. So we continue to either hold meetings, we have outgoing communications via email, lots of different, and even recorded webinars like this one, or similar types of recordings that we can send out. And it's going to take a while before we're all the way there, to be honest.
All right, one more question. You described potential upside to these models, i.e. increased primary care practice revenue. However, what were the significant direct costs or investments to get to this point?
Sure. In our case, we had some advantages, as I mentioned, because we didn't need to form separate structure to be an ACO. We were set up to do it already, so we didn't have separate infrastructure to fund. However, we have had to fund a few things. The care coordinator positions. Generally, in our case, we've hired RNs. In some cases, social workers are hired. And so you have to look at what's the right mix of TCM, CCM, different pay-for-performance activities they can do, that after you pay the provider their portion, that you can come out ahead as a health system. And depending on how you pay your providers, that equation might look different at different places. A lot of organizations invest in different types of analytics tools. We were, I don't know if you want to say lucky, but we have experience with that on our HMO side. It's not, we use Access databases and we use Excel. We don't have a lot of fancy tools, but they have gotten the job done for the last 20 or so years. So we've been able to piggyback on that work and to do claims data analysis without investing in a lot of fancy tools that we didn't already have as a health system. So, I mean, the average ACO spends $2 million in startup costs and about $1 million in operating expenses just for IT, I think is what the most recent survey from their association, ACO association, said. So there are startup costs, of course. In our case, we had some advantages going into it that we've been able to leverage.
Great. One more question. How does your organization utilize evidence-based care?
Sure. Well, a couple of things that come to mind. The quality measures are based around evidence-based care. Around, at least, I mean, evidence, I guess, is debatable because it seems like for every study that shows one thing, there's something showing the other. But by and large, there's consensus around general things like A1C levels. If you can manage patients' A1C and they can keep it below a certain level, then they're likely to avoid a flare-up and stay out of the hospital. There's fairly good consensus around that. What we've been able to do is we generally go right to providers there, or we take an interdisciplinary team and say, how are we going to satisfy this quality measure, because it is an evidence-based measure, and we really drill that this is based around good evidence-based care. That's why we're doing it. It's for the patient, but it also has this financial impact based on the quality measure. So we've been doing a lot of work with diabetes. We have a diabetes steering committee that consists of providers, nurses, administrators, data experts, who look at order sets, standing orders that could potentially be in place safely. So different ways those are a few different ways that we've approached that.
Thank you. That answers all of the questions. I would like to thank LAD for taking the time to put together this excellent webinar. What a great way to kick off the MHA Alumni Webinar Series. And thank you all for joining us today. We'll be sending a follow-up survey, and we would appreciate any feedback to guide the committee as we start to plan for the next webinar. And more details on that can be found at mhalumni.umn.edu. Thank you.